Welcome to AETCM, the emergency medicine channel.
Yes.
A 65-year-old female presented to the ER with complaints of right side abdominal pain since 2 days. On our initial 10-second assessment, the patient was conscious, oriented, obeying commands. Coming to airway was patent, no secretions. Coming to breathing, air entry bilaterally equal, respiratory rate of 20 per minute, saturation of 98% in room air. Coming to circulation, BP of 160 bar 100 millimeters of mercury, pulse rate of 81 per minute. Coming to disability, GCS of E4, V5, M6, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 98.2 degree Fahrenheit with a GRBS of 130 milligram per deciliter. The patient gives a pain score of 4 by 10. So injection PCM 1 gram IV stat was given at this point of time. At this point of time, we have sent the routine blood investigations. Coming to ambulatory history, a 65-year-old female, known case of type 2 diabetes, hypertension, presented to the ER with complaints of right side abdominal pain since 2 days. It was colicky and intermittent in nature, radiating from right loin to groin region. No history of any fever, hematuria, decreased urine output, dysuria, no other associated symptoms, no aggravating or relieving factors. No history of any allergies. On medical history, the patient was taking tab, glimepiride, Janumet for as OHAs for diabetes mellitus, cilnidipine, bisoprolol, and losartan for hypertension control. Losartan was started 1 week back. No history of any similar episodes in the past. The last meal was taken at 9 a.m. Coming to general examination, pallor was present, no icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, GIT, abdomen was soft, right side mild tenderness was present in the iliac region, no hepatosplenomegaly. Respiratory system, air entry bilaterally equal, no added sounds. CVS S1, S2 were present. CNS examination, GCS was 15 by 15, moving all 4 limbs. At this point of time, we have admitted the patient and sent all the routine investigations. Labs came as HB was showing 11.5, and other abnormality which we noted was a creatinine of 2.7 with a urea of 88. 1 week back, her creatinine was 0.7. Other lab parameters were within normal limits. We have also did a USG abdomen for this patient, which showed a mild fatty liver. So in view of raised creatinine, we have evaluated the cause of AKI and we have sent URE everything. URE was within normal limits and nothing abnormal was there. We have also got the history of the patient was initiated on losartan 1 week back. And we have calculated the ratio 1:2, but it was more suggestive of a pre-renal failure. 1 creatinine ratio was more than 20. So we have searched for the causes of pre-renal failure, and we thought it was most likely due to losartan. After ruling out other causes, CBC, CRP, everything was normal limits. Only abnormality was raised creatinine and urea. ECG was also taken, which was showing normal sinus rhythm, no LVH. Potassium was 4.3, borderline. We stopped the medication and we started. The patient also showed some dehydration, started giving IV fluids. 2 days down the lane, we have repeated the creatinine levels. Creatinine came to be 1.45 with urea of 40. Then we have monitored the lab parameters next 2 days, and BP was within control, and we stopped the losartan. We suspect it to be an acute kidney injury secondary to pre-renal failure with a KDIGO classification of 2, which is, and it is drug induced, suspecting losartan. We have stopped the medications, BP was under control, and the patient was discharged after 4 days.
Okay. What is paradoxical hypertension?
Most commonly seen in pheochromocytomas. Hypotension alternating with hypotension.
Okay. Hypertension?
Hypertension alternating with
paradoxical hypertension. Hypertension. What is it? One is what you told is correct.
Hypertension.
Paradoxical hypertension is you are starting one medicine for hypertension, but that itself inducing high BP. One is pheochromocytoma, where the patient is having alpha activity, increased alpha activity. When you are starting beta blocker, it will produce unopposed alpha activity and BP will increase. Second thing is, a patient who is having renal artery stenosis, when you are starting AC inhibitor, that artery stenosis like severity can suddenly increase. Patient develops renal failure and high BP. Okay, these are two conditions where BP increases after starting a medication for BP. Okay, but here it is not BP increase. Patient has developed renal failure. What is the reason for renal failure in AC inhibitor or ARB induced renal failure?
So the mechanism of causing prerenal failure in ACE inhibitors is the renal vasoconstriction.
Vasoconstriction. Okay, so what will happen?
The perfusion will be decreased.
Okay. So suddenly in some patients, especially where there is a minimal stenosis of the renal artery or without also that can happen, suddenly the blood supply to the kidney will be reduced. It will not happen in all the patients. Very rarely it can happen and patient may go to renal failure. That's why all patients whom we are starting on AC inhibitor ARB, we have to check the creatinine after 1 or 2 weeks. Okay. Same like that, if the patient's creatinine levels are raising, at one point of time, if the creatinine elevates more than 3, 2.9, then we better stop the drug because that can suddenly aggravate the problem in renal failure. Okay. What are the other problems which can be created by AC inhibitor, ARBs, other adverse effects? One is sudden renal failure due to renal artery stenosis or renal vascular shutdown. Okay.
Pedal edema can be.
Pedal edema is not a feature of AC inhibitor or ARB. It cannot happen. It is happening in AC calcium channel block. What else? Here one more problem is there. Dry cough is a feature of AC inhibitor, not ARB. One more problem is there in this patient. That may be part of renal failure, may be part of AC inhibitor ARB.
Anemia.
Hyperkalemia. Hyperkalemia is another problem which can be created by AC inhibitor ARB, especially when the patient is having renal failure. What is the action of AC inhibitor ARB? Potassium.
Sodium and water retention.
Sodium and water
excretion and
potassium retention. Okay. So another problem is hyponatremia. So hyponatremia and hyperkalemia can be produced by some patients with AC inhibitors. Then any other problem, serious problem, not serious, but these patients can come to emergency department. What is that problem? AC or ARB can induce angioedema. So that is one of the most common condition, not common means one of the most common side effect of that drug, angioedema.
People with hereditary angioneurotic edema.
So angioneurotic edema is one of the clinical manifestation of this one. Okay. Can you give AC inhibitor ARB in pregnancy?
No,
it cannot be. Can you give AC inhibitor ARB in aortic stenosis, carotid stenosis, carotid artery stenosis? Is it advisable?
Further vasoconstriction.
Vasoconstriction. Vasoconstriction is only in kidney, not other outside. It is a vasodilator. It can be given. So it is better to avoid AC inhibitor ARBs when there is a significant carotid artery stenosis because when you are starting this drug, there is a high chance of peripheral vasodilatation and central reduced circulation because of this stenosis. Okay, so these drugs are avoided in such conditions. But the most common contraindication is pregnancy. Okay, pregnancy is the main contraindication and renal artery stenosis. Single kidney also sometimes we don't give. There is also relative contraindication because we don't know what will happen to that kidney. So single kidney better to avoid this one. So how is the treatment for acute renal failure? Any condition, how do you manage?
Sir, when a patient came with acute kidney injury, the things we are anticipating is patient can have uremia, acidosis, extravascular fluid expansion, features of pulmonary edema can be there, and hyperkalemia. Once we have to look into this, we will take a VBG, ECG to look for acidosis, hyperkalemia features. If there is hyperkalemia, significant hyperkalemia, we need to manage hyperkalemia at that point of time. Then we will look into we need to classify whether it is a pre-renal AKI or a renal injury, whether it is ischemic 18 or interstitial nephritis or post-renal. In pre-renal AKI, the URE will be mostly normal. Patient will respond to fluids and
So here better you give some fluids. Patient can reverse the problem because it's a renal artery stenosis, and if on top of that he has developed minimal fluid deficiency, if you give fluid, sometimes it will improve. Okay. What is J curve response? Is it comes under that category, this problem? J curve response. What is that?
J-curve phenomenon, sir, when we suddenly reduces the BP, already since the patient is chronic hypertension, the perfusion is maintained with high BP. If you suddenly reduce the BP, the perfusion will be low, so it can affect the organs, kidneys,
It's
heart.
like J. When you reduce it slightly, the problem will be very high. Okay. So when you are reducing the BP drastically, sometimes there will be adverse effects in the kidney, heart, kidney, and brain. Okay. That is because your perfusion pressure is maintained for a long time with high BP. Suddenly, if you are dropping down that, patient can have kidney damage. Okay. This phenomenon is called as J curve response. But AC inhibitors are known to produce all these problems. So we have to be very careful when we are starting. The message is only very clear. When you are starting AC inhibitor, it is always better to check the creatinine after 2 days, after 2 more weeks. Then every 6 months you have to check the creatinine. There is a chance of increase in creatinine, especially when the patient is having diabetes. Okay. What happened to the patient?
We have started giving IV fluids and we have stopped the drugs, sir.
Okay.
After 4 days, the creatinine became to 1, sir, from 2.7 to 1.
Okay. Potassium, what treatment you had given?
Initially, the potassium was 4.3, sir, with no ECG changes. We have stopped the drug and repeat the potassium after 1 day. Okay. It was normal, coming to
when will you treat hyperkalemia in a patient with high potassium? What time you will start your treatment?
If the patient is having ECG changes, most likely, sir.
What are the ECG changes?
Tall T waves, most common in bradycardia. Patient will be having bradycardia. Tall T waves, height of P will be decreased, slightly prolonged PR interval will be there.
Okay. Then, what is the latest stage of hyperkalemia?
The patient can finally into sine wave pattern.
Okay. Which is more dangerous, hyperkalemia in acute renal failure, hyperkalemia in chronic renal failure?
Acute renal failure.
Okay. So this condition, if the patient is having 5, 6 itself, it can be dangerous. But whereas in chronic renal failure, that may not be very problematic. How do you manage hyperkalemia?
Initially, we will give calcium gluconate 10%, 10 ml over 10 minutes. We will give, sir. Then we can give nebulizations. Will cause a shift of the potassium. Can be given, sir.
Then
dextrose, 8 units insulin, 5% dextrose. G bolus we will give, sir. Then sodium.
The patient is having renal output, Lasix is the best treatment. Patient is not having renal output, then dialysis. When will you give bicarbonate?
Patients in cardiac arrest, hyperkalemia.
Only if there is hyperkalemic cardiac arrest or impending cardiac arrest or cardiac failure, then bicarbonate may be useful. Otherwise, bicarbonate is not a very good drug because it can when you are giving bicarbonate, if the patient is already having cardiac failure, that can aggravate. But slow infusion may not be a problematic thing. Okay. What happened to this patient afterwards?
Later, after 1 week, we have called for review. The creatinine was 0.7.
So, what are the alternatives for AC inhibitors in renal disease, diabetic renal disease?
We can give calcium channel blockers. We have started, sir. Then we can other drugs we can give according to newer guidelines. KDIGO 2004 guidelines. We can start dapagliflozins can be given.
Okay.
The patient was also on bisoprolol also. So.
Okay. Bisoprolol. Okay. Bisoprolol is started for hypertension. Okay. So in renal failure, bisoprolol can it produce problem or is it safe?
Bisoprolol ideally we give for if the patient is having CAD. Beta blockers are the line of choice.
What is Brash syndrome?
Bradycardia, renal failure.
So you have to read about Brash syndrome. See, one of the problem of beta blockers in renal failure, especially when the potassium is high. Okay, the beta blocker itself can produce hyperkalemia, and renal failure also can produce hyperkalemia. Both can produce severe bradycardia. So that will be a dangerous combination. Okay, so you have to be very careful in renal failure, not in this case. This case is only acute renal failure produced by AC inhibitor. It is reversible. But in a renal failure patient, when you are starting beta blocker, you have to be very careful. Patient can go to complete heart block. So we have to be very careful. So that is called as Brad syndrome. You have to read about that. Okay, it's very simple that two combinations which can produce bradycardia. Okay. What else you want to tell?
So for AKI, it's a renal failure that develops over hours to days and characterized by uremia, acidosis, hyperkalemia, and easy volume expansion, sir. Once we diagnose a case with AKI, first we need to triage it into whether it is a pre-renal or a renal or a post-renal, sir. Pre-renal, the output will be maintained with URE will be normal, sir. But the renal, the output will be affected, and you can see URE will have abnormalities, sir. To differentiate between pre-renal and renal, the urine output will be normal, almost will be normal in pre-renal, but decrease in renal. In URE, there will be no albumin in pre-renal, but albumin will be present, and urine microscopy will show muddy brown cells, WBC cast in renal, we can see, but urine microscopy will almost be normal. Coming to how to identify pre-renal, the bun creatinine ratio will be more than 20 in pre-renal, and mostly it will be less than 10 in renal injuries. And the gold standard is FENA. We will calculate the FENA. FENA will be less than 1% in pre-renal and more than 2 in renal, sir.
What is FENA? FENA is what?
We will calculate based on the sodium and the creatinine levels.
Fractional excretion
of sodium. The urine specific gravity and urine pH will be mostly normal, but it is variable in renal, sir. Ideally, you have to look for the URE, then come to a diagnosis of pre-renal, renal, and post-renal.
What is fixed specific gravity? Fixed specific gravity of urine.
0.10.
1010.
1.010.
So that is a fixed specific gravity continuously. If you are seeing in urine, then that is a finding of renal failure.
Then initially we have to differentiate whether it is an AKI or a CKD, sir. You have to go take a UST for the patient. If you don't know the baseline creatinine, take the UST. If the UST shows asymmetric kidneys and the CMD is not maintained, it will point towards a CKD, sir. Otherwise, most probably it will be an AKI, sir. Coming to pre-renal causes, there are 6 mechanisms of causing pre-renal injuries. Most is intravascular volume depletion, that is seen in vomiting, diarrhea, hemorrhage, and blood loss. The decreased effective intravascular volume that we will see in cirrhosis, decreased cardiac output in cardiorenal syndrome.
What is it called as? Hepatorenal syndrome. Hepatorenal syndrome, there will be reduction in the kidney perfusion. Okay.
And in sepsis, initially there will be...
Cardiorenal syndrome also same, reduction in the blood supply to kidneys.
In sepsis, initially there will be a pre-renal stage, then the patient will come to ischemic ATM. The widespread systemic vasodilatation, microthrombi, and endothelial leak will lead to the pre-renal injuries. In drugs like NSAIDs, ACE inhibitors, renal vasoconstriction is the mechanism of causing pre-renal. Then we come to the renal injury. Renal, most commonly ischemic ATN and acute interstitial nephritis. In ischemic ATN, mostly caused by toxins, decreased urine output, and URE will show abnormalities. In
NSAIDs produce what type of
mostly pre-renal.
They also produce vasoconstriction and pre-renal. They can sometimes produce ATN also.
Interstitial nephritis, mostly it is an hypersensitivity reaction, sir. Urine analysis mostly show proteinuria and WBC cast.
That is DRUS syndrome. DRUS. We had a patient, DRUS. It is something related to drug. You have to read about that. We had a patient, DRUS syndrome. Okay.
Then the drugs that cause pre-renal, mostly NSAIDs and ACE inhibitors, sir. ATN will be mostly vanco and aminoglycoside, interstitial nephritis, beta-lactams and rifampicin.
So when we are starting a lot of vancomycin in our ICU, what precautions you will take when you are giving vancomycin?
We will look at the creatinine initially, sir.
How many days it will take to produce renal failure in vancomycin? So after it is a cumulative dose effect. After 3 or 4 days only you will see that. First dose will not produce normally kidney failure, but rarely idiosyncratic reaction can produce. First dose itself patient can develop. Okay. What is Redman syndrome?
Flushing, everything secondary to vancomycin, sir.
Secondary to vancomycin.
After taking
So
allergic
we are
reaction.
giving it is not simple allergic reaction. We are giving lot of vancomycin in ICU. You are not seeing. What is the reason for that? You are not seeing. So what is dress? Dress is different. This is Redman syndrome.
Redmans.
What is the reason? This is due to faster infusion of the drug, not because of the drug. So you have to give very slowly. Vancomycin should be given very slowly infusion. If you give faster rate, patient can have flushing, red color all over the skin, and it is reversible. Okay. So that will be confused with the drug reaction. That's why.
And then newer updates are in CKD patients. According to KEDICO 2024 guidelines, first line agent we can also think about dapagliflozin
Okay.
once the GFR is more than 20.
Okay. Tell something about NGAL.
NCALs are more sensitive and much more early we can detect renal injuries
Okay.
than creatinine.
Especially in drug-induced, contrast-induced renal failure. Okay. But since it is not available everywhere, it is costly. We are not using it. Okay. Anything else you want to add? Okay. Thank you.